Good evening.
Good evening, sir. Uh, just a quick check, sir. If you are able to hear me and see me clearly.
Yes, absolutely.
Thank you so much. I can see Dr. Anand is also very much here. Very good evening, Dr. Anand. Such a pleasure. Yes, now you have unmuted. That's so wonderful.
Thank you so much. My regards to the organizers, especially Dr. Kumar, our president. In fact, it's a wonderful job what you people are doing to teach the people, to give some kind of ideas that how we can prevent the better health treatment. The second part which we all are doing,
Correct,
so can we start?
Yeah, thank you so much, sir. Just a brief, quick inaugural brief and some housekeeping, and then definitely this e-platform would be all yours for the deliberation and for the knowledge session that we are going to get from you. Thank you so much. With this, just checking, quick check with the secretariat. All good?
All good, sir.
Thank you so much. Please. So once again, a very good evening. I am Dr. Pavan Gupta, as member executive committee of Indian Association of Occupational Health AUSG Delhi branch and secretary of Haryana branch of Indian Association of Occupational Health. Such a wonderful site every Saturday evening at 6:30 p.m. This has been a continuous phenomena almost a year now, and we have recently celebrated our Diamond Jubilee, I guess, right? And it has been possible only because of the continuous support of our esteemed panelists, the key stakeholders, and office bearers of AUSD. And I mean, it goes without saying that Dr. Sandeep Sharma has done an astounding task of putting everything together and driving it all through with great support from Secretariat. And then, yes, our very own Dr. Rajiv Jain, who has been continuously giving wonderful and also a continuous updates on COVID-19 situation. So that was a quick brief on what we have been doing and how we are proceeding now. On behalf of AUSD, extending a very warm welcome to all esteemed panelists, all the attendees, and the key office bearers, and definitely the audience, without whom everything goes for a toss. So, gratitude and thanks to all for joining and also for giving this opportunity to me once again moderate this wonderful session. We will have some good questions for the speakers, and we have received some feedback, and we will see how best we can take it ahead. As always, it will be 20 minutes of session followed by 10 minutes of question and answers. And I request all panelists and also all the attendees to please keep posting your question and answers, and also in Q&A box, or you can directly text me, or you can post in the message box as well. We will take all the questions. You can raise your hand as well. In the order of their appearance, we will try to take up all the questions. If anything remains, we will definitely get back to you one-to-one, or maybe we'll connect you with the speakers later on so that you can get your queries resolved. So that was a little bit of housekeeping, and with that, I would request our Honorable President of AUSD, Dr. Kumar sir, to please give the inaugural address and give the permission to take it ahead. Over to Dr. Kumar sir.
Thank you, Dr. Pavan.
Thank you so much.
Good evening, friends.
Good evening,
I welcome you all to this 80th issue of our WDG Connect series. It is now it is almost 2 years now, going to be 2 years, that we are regularly organizing this webinar on every Saturday at 6:30 p.m. And the speakers from different streams, different disciplines, they come and they deliberate on different topics, and all our speakers are always of eminence. So in this series, today we have got Dr. O.P. Anand, who is a senior most eye surgeon in the Indian Railway, and he has a track record of the highest number of cataract operations performed in the railway medical system. And he is expert in the field. He is not only, biodata, once you will go through the biodata, Dr. Pavan, you will find how learned person he is. So we welcome you, Dr. O.P. Anand, to our program. and today he shall be discussing about cataract and relating to the occupational hazards. Our second speaker is Dr. R.K. Jain, who is our Vice President, and he will be updating on the COVID situation internationally and in the country. With these few words, I welcome both the speakers, I welcome all the participants, and I welcome all the guests. Thank you very much.
Thank you so much, sir, for your kind gesture. Really appreciate Dr. Gajan Kumar, sir. And with that, without taking any further minute, I would like to introduce Dr. Anand, our eminent speaker, first speaker of the day. And then, as Dr. Gajan Kumar has mentioned, we'll proceed with the session of Dr. Rajiv Kumar Jain. So it's a great feeling, definitely, to introduce Dr. Anand. And Dr. O.P. Anand is currently working as head of the department and chief eye surgeon, Northern Railways, Central Hospital, New Delhi. Dr. Anand is a regular expert on All India Radio and Lok Sabha TV. We have a celebrity then amongst us. Thank you so much, Dr. Anand, for that, and many congratulations on your achievement of having the highest number of surgeries in your name. That's really wonderful. We congratulate you from bottom of our heart. Then there are more accomplishment. He's a postgraduate teacher and guide from last 15 years. He's Dr. Anand is a DNB examiner from last 10 years. He is past president of Faridabad Ophthalmologists Society and Railway Ophthalmologists Association of India. He is the chairman of Constitution Amendment Committee, Delhi Ophthalmological Society. At present, Dr. Anand is the executive member of Delhi Ophthalmological Society. Thank you so much, Dr. Anand, for spending your time today for us, and many congratulations on your achievements. We look forward to hearing you and learning from you. All this e-platform is all yours now.
Oh, thank you, boss. Really, I am really honored to be here in between the very learned people, and we people are doing such a great job. And the word you have given, a kind word rather, I should say, I don't deserve for it, but we are all like we are doing the government job, and whatever best we can for we always try. Really, I am really thankful from bottom of my heart, boss. Thank you so much. So I will try to explain how we related to the cataract. As you know, we are also working in an institute which is industrial health. Number of labor we are having with us. So we are come across. So I will try to brief, though it is a very large and vast topic. It's very difficult to be covered with it. I will try maximum what I can do. Right?
Sure, sir. Sure.
Thank you so much.
Most welcome, sir. Okay.
In fact, my presentation is coming behind the screen. I can't see it. So how I manage?
Oh, is it? So, if you can minimize the front window, sir.
Okay.
Then, a couple of more windows. If you can minimize, then definitely we'll be able to see the presentation. Yeah, that's one. That second.
I want to take second one.
No, you should take your time.
Yeah.
No problem. Just in case you have mailed your presentation to us, we can definitely present that.
Actually, this under this kind of picture, it is gone behind. So
okay.
I will take it out.
Yeah, maybe you can click on the presentation part, and that would be up on the screen. The present.
Yeah, this is different. Actually, the presentation are in number of download.
Okay. Okay.
Yeah. So I'm just trying to find out that, but
Okay. No problem, sir. Please take your time. In case Secretariat, by any chance, for all the support that he has always extended and with great words that he had been supporting us all through a couple of years, I would say. Dr. Sashi Bhushan, key office bearer of AUHD. Thank you so much for joining in, Dr. Bhushan. And yes, Dr. Siva, thank you for sparing time.
Can you see now?
Uh,
Presentation.
We cannot see, sir. Maybe you will, if you will share the screen. As of now, we can see our screens. Mhm.
Secretariat, have you received the mail?
I have sent it.
Yeah.
Secretariat, I'm asking.
आप जरा एक second.
Yes, sir. I'm looking for it, sir.
Yeah. It may take a while because it will be.
Is it visible now?
No, sir. Not
Yes.
yet.
Not yet?
No, not yet. Not yet.
Okay, 1 minute.
Sir, I've received the mail. Just give me a second, sir.
WhatsApp it?
Yes.
Just give me a second, sir. Just give me a second.
Okay.
That's perfect. We are definitely looking forward to an interesting session from Dr. Rajiv Kumar Jain today because of the emerging COVID-19 situation across the globe. European countries looking towards the lockdown situation, East Asian countries as well. Dr. Rajiv Jain has definitely already given some insights on the group, occupational health group that we have, and we look forward to some interesting and also some feedback also on the way forward, the way things are changing and the dynamics are changing as far as COVID-19 situation is concerned, wherein Honorable Prime Minister has also mentioned today to review the conditions of the travel restrictions or to easing the travel restriction. He has also advised the committee to please review the same because of the emerging dynamics of COVID-19. So it will be an interesting session as we hope, and he has already shared that he will be sharing some details. So we look forward to that. And yes, I look forward to interactions from the audience and from the panelists as well. Some good, definitely some wonderful questions. Yes,
it has come.
Perfect.
Yes.
It is very much visible, sir. Is it visible to you?
Yeah, definitely.
Okay, so you just have to guide the secretariat to change the screen, change the slides, and then it will be very smooth and flawless. Please guide us.
Perfect.
Yes.
Perfect. Okay, so
over to you. Thanks.
Thank you. I'm sorry for the delay because I don't know what some system setting is there. So in fact, the cataract, as you know, it's definitely an industrial hazard because what we have seen, the number of cataract cases are more in the population which have certain kind of factors along with them. The main important is the tropical countries where the ultraviolet rays are very much prominent, and even that area where they are most prominent or very sunny days. So the people who are working in the sunlight, they are getting more cataract problems. It has been observed and studied at various levels. Can you have the next slide, please? So how you define, if you talk of the definition, any of specification in the crystalline lens and or its capsule. I mean, we have the lens like in a camera in the eyes. It is transparent. It is basic purpose to give the refractive power to the eye, and it focused the rays which are coming from outside at the retina, and we will get the image. So that is the job of it. Once it get opacify, the entry of the light get reduced or sometimes stop completely, and the patient will have blurred vision or no vision at all. So next slide, I will let you know. Yes. So this is the next slide where I can tell you that what we are talking about the capsule. This is the lens. In fact, this is the cornea. You can see this part is cornea, iris over here, and lens is just hanged behind the this iris. This is the lens. It's around 9 millimeter to 4 millimeter. If we talk is 4 millimeter, and this is 9 millimeter depth. And further, if you go for its structure, you can find this is the active surface, what you call the anterior capsule, have the epithelium, or the lens grows from it. You may surprised to know that lens grow whole of the life. Its growth is constant till patient exists. So the maximum growth, what the expert has find out, it is around 0.029 millimeter per year. So this is the growth expected. And how we can see once we make the slit lamp, there is one special equipment the ophthalmologist normally use. So we have to see a cut section in the exam center. So you can see the lens from behind to outside, the periphery, everywhere is there any kind of thing. Next slide, please. So this is again one more picture of the lens where we can see that this is the adult lens and have the different segment. Actually, these are the parts where the lens get developed. The earliest one, what you call the neonatal kind of lens, and then it grow outside and keep on increasing. Posterior capsule. This is a posterior capsule which normally remain transparent, and it is semi-permeable also, and it is the active capsule which have the total metabolic activity and responsible to the growth of the lens. Next slide, please. So now we have talked about it. Then we can think that who are the people who can develop cataract. So I just tell you that in Western countries, because we are having very poor data in our country, I don't know why, that in Western countries, a person at the age of 80 years either have cataract or have the evidence of cataract surgery. So 50% people at the age of 80 or in our country around 60 are having some amount of cataract. It may affect their lifestyle or not. That depends what the kind of work this person is doing and what the site of the cataract in fact. Suppose in the central, it affects more. It is in the periphery. I mean, it can go even unnoticed. So there is a congenital relation with the cataract formation. So there are some kind of heredity, gestation maldevelopment, maternal malnutrition, infection, so many drugs, radiation, maybe a X-ray or any other type of radiation, anoxia, metabolic disorder, birth trauma, malnutrition. They are the main causes of the cataract formation which a child face in their life. And despite that, what I'm trying to say that is more important, that 30% people, 30% child have no reason of getting cataract. So it's a very high number of the child who are getting cataract and born with cataract. And this quite 30% of them. Senile, as I have just told you, that it is basically a problem of age related. So we call it the senile cataract. Few category of patient we can found that it could be pre-senile. So the senile, they said the dehydration, systemic disease, smoking, oxidative stress, and lack of essential dietary element. I mean, these are the things which can prone the person to get early cataract. Normally, suppose somebody get the age of 70, I just told you, the age at the age of 80 years, everyone have some amount of cataract. So these risky category people are having definitely the more incidence of cataract. Trauma, it is definitely associated with the industrial health, the kind of occupation or profession the person is having. I have seen number of people like the hammermen, the welders, the people who are working on the roads. They are getting different kind of trauma. Few are getting blunt, few are getting penetrating, but all lead cataract formation. And these you may find that the people who are getting this kind of traumatic cataract are of very young age. And sometimes the trauma is so big, is so severe that despite your best effort, you can't restore the vision. Complicate cataract because of some other disease. So metabolic cataract, the diabetes is the main culprit for getting the metabolic cataract in our country. As you know, that high number of people are having diabetes, and it is absolutely related to that. Then when the diabetic people definitely have a presenile, what the study has shown that a diabetic may develop cataract at least 15 years younger to their age group. So it is a cause of presenile cataract. The toxic, lot of toxic substance, including some medicines, are having the cataract formation. Radiation, like infrared, like X-ray, ultraviolet rays, and powerful electric current, etc., they all can lead cataract formation because ultimately they affect the metabolic activity and physiological activity happen in the lens. So lens having a very high quality metabolic and physiological activities, they can affect with a small insult to that and can lead the opacification or the formation of cataract. Next. So what is the pathophysiology? Can we talk in a brief that the different industrial relations with that? The radiation cataract is one of the most common cataract happening to the people who are exposed to it. So their safety is must. The prevention, the safety guards, the gadgets has to be given to these people, and the periodical examination of this kind of people has to be a common feature to prevent the bad effect of the radiation on the eye. So cataract induced by ionizing radiation like X-ray, gamma rays observed in the posterior region of the lens. Like we have just talked to, that lens have a anterior part and a posterior part, the periphery. So they said that the posterior part, which is normally free and totally transparent, get the early development of cataract formation. What you call is the posterior subcapsular cataract. Increasing dose of ionizing radiation cause opacification of the lens, which appear after a decreasing latency period, and they affect the metabolism of the lens membrane. Another possible mechanism is damage to lens, decrease in the production of protective enzyme. So definitely the lens have its own protective system, and which keep on preventing by creating some kind of enzyme, and with the radiation, these number of the protein enzyme can reduce and can form the cataract. It is one of the most sensitive tissue of the body for radiation. Next slide. So how this kind of cataract look like? I mean, if you talk about the formation of cataract, you can definitely look the morphology of it, and you can find out the pathology or the reason behind getting the patient cataract formation. You can identify at least in early stage. Later on, this whole cataract became white and opaque, and then the differentiation is not possible. But if you put your employee on the regular examination, we can find and detect the cataract in the early stage, and they are the peculiar cataract of getting radiation impact. Next slide. Ultraviolet rays. So this is the long chain of the physiological activity which happen and prevent the normal growth and function of the lens and lead cataract formation. I have just told you that whatever insult is happened in any form to the lens, it just lost its transparency and became opaque. So that is the problem with it. So ultraviolet rays, any light which is not visible or less than the 295 micrometer. So these are the very small wavelength rays, and they have high energy. In fact, luckily their penetration is less. So, but some kind of profession. So this is, I don't want to go in detail of it, that how it affected, but ultimately it lead the formation of cataract because of various mechanisms by preventing the protective measures taken by the lens itself, and by creating some kind of advanced glycation product. So these products get accumulated in a faster rate and affect the basic metabolism of the lens and get the cataract formation. I have seen that people who are working in the field, like the farmers or the people who are residing in the area where they normally expose for the highlight, like the coastal people in Rajasthan, the cataract formation in these people group of people is very high. I have seen the cataract formation majority people at the age of 40 and 45, depending on their exposure outside. So ultraviolet rays are definitely very dangerous in our country. We should take always the protective gadget while we are going out or when we are going in the bright light, because these rays which enters freely. Here I would like to say one thing, that number of protective glasses are not really protecting ultraviolet rays. I have in so many, I was just telling you that on radio and on Lok Sabha TV, people normally ask what kind of protective glass we should have. So our eyes are becoming protective because number of glasses are being sold on the roadside, what you call the dark glasses. These dark glasses, I will just like to tell you here, they are even more dangerous, because what happened that these glasses are not equipped with the UV rays protective devices or that kind of material. So because of the darkness, the people get dilated and even more light enters. So more ultraviolet rays are being entering and the person indirectly getting the more damage to the eye. So once you are selecting the glasses for your eye to protect the ultraviolet, you should be very sure that they should have at least the protection for ultraviolet rays. So there are so many ways we can check it. Next slide. So this is a typical cataract where we can find the total lens is opacified, and this is the vision of this this patient dropped to almost to the minimum, and it's totally look white. If anybody look in the eye of the patient, they found the white reflex. So that's why we call it as a motiaband. It look like moti. So that is the name given to it. And ultraviolet rays, even the advanced cataract of any region behind became white ultimately. Next slide, please. There is one category. I have just taken the name of glass blowers here, but it is not limited to that only. Anyone who is working near the hot environment, high temperature, like the furnaces, like the welding machines, like the anywhere where the gases are being used, where the hot temperature are being used just to design, make their product or to work in the factory. So these all kind of people are having a great deal of infrared radiation, and this infrared radiation make lot of biochemical changes to convert the transparent protein into the non-transparent. These glass blower or the people who are working in the furnace are having a typical kind of the eye, what you call, it's a exfoliation. We are having two category of the patient, like the false exfoliation and one is a true. So where the lens capsule get damaged, it's start peeling off, getting thinned out, the zonules became weak, and the lens material became opaque. So this is the common presentation of all the people who are working near the hot temperature for some reason, and glass blower is one of the example of that. So we have to have the protection to given to these people by protective glasses or periodically change their life, their profession. So anyhow, we have to look very closely to the people who are working in very high temperature, and they are more prone to develop cataract, in fact. Next slide, please. So how the cataract look like? This is one of the very disturbing cataract for the surgeon even. You can see the capsule is getting damage here. There are the iris pigments and the even the iris is not very healthy outside. So these patients are having difficult surgery as well. They develop cataract very fast and very short duration, and the surgery, which is the main treatment of cataract for any case, became also little difficult, because sometimes the zonules get weak and we are not able to place the lens of proper size, and their prognosis remain explained that your vision or your cataract surgery may not be as successful as we are looking for. Next, electric shock. Yes, all people who are working in this department pass any kind of current from one body, from their body, may not be life-threatening, but if passed from the eye, even a small current, even the millivolts, can convert the protein of the lens into a non-coagulating protein or the opaque proteins, and it can develop instant. Like the exact pathway of cataract development is definitely unknown, but the coagulation of lens protein is one of the idea that it can lead the coagulation because of the electric current passing through, and the osmotic change following the following passing the current, and the subcapsular epithelium are thought to be responsible. They said that the osmotic, the lens is having a own control of moving the fluid from inside to outside and from outside the inside. Lens, basically, I have just told you that it is basically immersed into the aqueous from anterior to posterior side. So यार समझिए कि पानी के अंदर ये पड़ा रहता है, and इसकी जो membranes हैं, they are basically a protective part. Any insult to these membrane allow lot of water inside, and lens can get swell up, its fiber get opaque, and person develop cataract with immediate effect. So they are the two basic mechanisms by which we people are looking for cataract. But ultimately, any patient any person like who exposed to the electric circuit is definitely develop cataract. Next slide. So in early stage, this kind of cataract you can find in case of the patient. Like this is the retina over here. You can see the globe here. This is the lens which is almost totally opaque and totally cloudy. So it happened because of the immediate precipitation of the protein. So rest retina you can see. Next slide, please. So one of the more important part of the traumatic cataract what we are talking about is that traumatic cataract is the main part in the occupational hazards, industrial hazard, where a lot of work is going on. We are working near the moving machine. We are working with the hammers. We are working with the flying object kind of thing, which can release from any of the machine or any of the material and can affect the eye. So traumatic cataract in railway, I have seen number of people who are getting cataract formation. They exposed to the blunt trauma, even the players, the tennis ball player, the golf player, if they are hit by any of the blunt object in the eye, they can seriously affect it and can lead the formation of cataract within a week. So trauma is one of the most important factor which can lead cataract formation in the person working in the industrial organization. The main industry, main people I have seen is the flying iron bodies like the hammerman, main working people with that, or they are just standing even near to that, or any moving machine which is lathing or doing that kind of work. So any small particle just fly off and enter into the eye. So I have seen number of people who are getting this kind of cataract in industrial, in particular railway, because my maximum people are working on the track or in the workshops, and they are really exposed to this kind of the trauma, and they are getting cataract in very early stage. Very bad shaped cataract I have seen. So most traumatic cataract are intumescent. It is always happen with the blunt traumas, but their type and killing depend on the trauma and mechanism and the integrity of the capsule. So suppose I am talking of the penetrating injuries, any flying object pierces the eye layers and can disturb the capsule. And once the capsule is disturbed, the water which is in which the aqueous, in which the lens is present, it enter into the lens and can develop cataract within hours. So basically, we have to say that all people who are working in the industry should have absolute protective devices, particularly for the lathe machine workers and the people who are working with hammer and chisels, or on the machines where a lot of things are being lathed out. So the classical cataract, I can just next slide, please. So this is the classical blunt trauma lead cataract. It is normally asked in the exam to these students that suppose sunflower cataract, it look like a flower. So this is the cataract formation inside it. It is in the center part of it, and it affects the vision badly. So this is the classical example of a blunt trauma cataract, but a penetrating trauma cataract may be of different, and it having the multiple injuries and the multiple level of management. Next slide, please. One thing I would like to bring in your notice that not only these laborers and workers, mechanics, lathemen or blacksmiths are exposed for the risk of developing cataract, but it is a study done recently where the cardiologist and the people who are working in the cath lab, they also found the high incidence of cataract formation. So even neither we people are also not away. We are not immune for it. So when we are working or exposed to the area where this kind of radiation is high, definitely we will also be develop cataract. So he said that radiation exposure during cardiac catheterization is very high, and all the people who are exposed to it, including the cardiologist, can develop cataract in early stage. So in which they have found that the high number and p-value is 0.09. So it's very, very significant. They have studied more than 2,559 people who are exposed for it, and they found the posterior opacity significantly higher in the IC workers compared to the control group or same age group. So my point of saying is here that the doctors and the people who are exposed in the radiation lab, the radiotherapy, the doctors, the para healthcare workers, they all are exposed. So this is a study done recently, and they have proved it that the cath lab where we don't expect that kind of radiation can happen. The orthopedic surgeons who are working with the CR or now the lot of navigation system is also, they are not free of the hazard. So we always be very careful, and we always take all protective measures to prevent ourselves. Next slide, please. So definitely I can conclude then cataract is definitely an industrial hazard, is definitely related to the occupation of the person, what he is doing. He definitely needs the protection. He need definitely the repeat medical examination. He repeatedly screen out to the presence of cataract in any of the eye, and if it is there, then they need to be shifted from that place, or some kind of surgery if advised in early stage to be given. So yes, we can say, it is a occupational hazard? Of course it is. The radiation induced cataract are dose dependent, and safety measure has to be taken. Glass blower, we have studied, they have found the maximum number of the cataract formation. Industrial accident, electrocution can also be prevented by observing the precautions to prevent it. So definitely I can say in one word that definitely is the wrong word. The prevention is better than cure, and we should prevent it anyway. Next slide, please. So when we talk about the cure is only the phacoemulsification, I mean the surgery. So we have now, if I'm not wrong, maybe more than hundreds type of cataract surgery people are doing, depending on the infrastructure and the experience of the surgeon, and definitely demand of the people. So phacoemulsification with IOL implantation. Now no surgery of cataract being done without IOL implantation in any case, because it is the only thing which can rehabilitate the vision in a better way. So phacoemulsification is the one of the commonest method to be operated for cataract patients with IOL implantation, is the standard treatment. Occupational cataract are often softer and can require the surgery of frequent level. So I mean they are not very of difficult kind except the penetrating injuries. So occupational cataract can be rehabilitated very well with these available surgical methods and with the available of advanced lenses. So it is the good thing with us. So I think we should take all preventive measures to the workers and even ourselves, because we are suppose on the risk of exposure to be developed cataract. I agree that there is a treatment available, but every treatment has some risk and some changes, and we should not forget all those. So we should not be overconfident for this. Next slide, please. Thank you very much.
Thank you so much, Dr. Anand, for wonderful insights. A topic so simple, explained so wonderfully. I think cataract is the most common ophthalmic issue. It's I don't know, I can comment like an expert, but I guess this is the most common issue that people face globally, and is the highest number when it comes to ophthalmic issue. Am I right, Anand?
You are absolutely correct. If you look for the surgery, if you look for ophthalmic surgery, it is almost a 70% part of total surgery we perform on eye.
Okay.
70%. Suppose we are performing 100% of surgery, 70% or even more than that are a part which is covered with the cataract surgery. So this is so much high. Number two, if you took the total number of major surgeries, even then the number of cataract surgeries are definitely sharing 50% of total surgery. So the cataract load is in worldwide is very, very high. And the countries like us, despite our best effort, we are having still the backlog, which is keep on increasing even today. And the reasons you know very well that the age are advancing. I told you it is the case of the problem of advancing age. So now we are getting advancing age, and this is the cost we are paying in development of the cataract. And second, the sensitivity. People are coming far much earlier for the cataract surgery. Initially, I have seen the people never come for the cataract surgery unless vision dropped to a very extent, very drastic level. But now people are coming with the very, very early stage. Simply they are having the blurring of vision and they come for the surgery in early stage. So that's why the backlog is keep on increasing regularly, what I am so observing. Okay. So it is a lifestyle, but we are having.
Thank you so much for confirming that, Dr. Anand. And I think, I mean, that's definitely issue which is topping the chart. We will see how best this community and this platform can contribute, wherein we can decrease the number over a period of time by raising awareness or various other alternate measures. But yes, inputs related to the sunglasses, inputs related to the high temperature zone working situation, inputs related to the blunt object injury, and also like sunflower cataract perspectives and others are definitely very well taken. And we will be keeping this. These e-platforms definitely give us an edge to record these interesting dialogues and also these interesting insights, and we can refer to it, because there is nothing better than a reciprocative dialogue in any at any platform at any given point of time. So I once again thank, and then we have a lot of questions. Dr. Anand, raise hands are there. So please, I would request you to please. And first, I think I'm going to Dr. Gajendra Kumar, President of AUHD. Over to you, sir, please.
First of all, I congratulate Dr. O.P. Anand for such a wonderful talk. He has made so many doubts clear, and the presentation was superb.
Yeah.
Now I got 3 questions, Dr. Anand, to you.
Ji, sir.
My first question is, as you said, the goggles, colored lenses, they can filter out the ultraviolet radiation, which is one of the main culprit in development of cataract.
Aging cataract.
So, but simultaneously, you have also said that the quality of the lens in the goggles, that matters.
Yes.
How a common person or a normal person, even I myself, go to the market, how I can confirm the goggles which I am buying is of appropriate quality and I will get prevention out of it, not the harm?
Yeah, it is definitely a very serious question to answer. In fact, what happened that the people are coming out with these very simple kind of plastic material. They are definitely cheap. And if you go for a branded one, they can have the device to check the filtration of ultraviolet rays. So the equipment is available. If somebody just want to check it, so it is possible that whatever glass you are wearing is really giving you complete protection or not. You can definitely check it. But what I want to say here that never go to glasses which are simply dark outside, because these glasses are indirectly they absorb the heat. They are not protecting the ultraviolet penetration into the eye. So they are affecting your eye in different manner. So not only ultraviolet, but they absorb the heat and put to the cornea and near to the eye. So your eye get a different environment and get the more incidence of formation of cataract. So what I feel that initially you should ask with the word that you should have 100% UV protection, and that is written on the glasses. Now the all glasses which are coming in the market with the brand not very costly are having this kind of feature mentioned inside. You just can check it. You can even see on the glass. Okay, this glass is definitely protecting your eye. So you cannot educate each and everyone, because this is the kind of trade going on outside. Thousands of people are purchasing the glasses from the roadside people, and these glasses we don't recommend. They are good. So better they should be avoided.
What should be the color of the glasses?
Any color. Any color. You may not believe that a transparent glass having the some kind of ingredient inside can protect the ultraviolet rays. Now, even if the white glass you are wearing, because these ultraviolet rays are absolutely non-visible. So they never have any part to have your vision. So they are not visible. So even your glass, we are having the coating of number of glasses with the ultraviolet protection paint. So they protect. But I mean, it is not only the colored glass. But I have seen number of people are using colored glasses just to protect on that. It is the I think it is a wrong perception, and which I want to stress out that people should not force to use, and they should be keep aware well that what glass you are taking to protect your eyes, not protecting in fact, rather they are harming you.
So are the photochromatic glasses are better vis-a-vis normal colored?
Sir, photochromatic glass, what now the concept of photochromatic glass has almost gone. The reason behind that, in photochromatic glasses, we had to put some kind of pigment which they get sensitized with the sunlight and they move to the center. And in the dark, they just scattered in the periphery. But what we have observed, and everybody observed, with time, this movement of the particle get very slow, and sometimes it never move inside in the center. So by the time you use glasses, they completely lost their photo protection. So they should not be used much.
Then my second question is,
sir,
in the congenital or cataracts, how early cataract surgery can be performed in a child?
This is one of the wonderful questions. I think it is beyond the occupational health, but it is very, very important because you are dealing with a newborn which has had long life later on. So the cataract surgery in a newborn is definitely a very important decision to be taken by that. Because if you don't operate the cataract in a newborn, after doing surgery, it will have no value. Because eye will be totally blunted, it will be amblyopic, and you do surgery or not do, the vision will not be provide back, right? So rehabilitation in these childs is very important. What we say that if you are both eye are having cataract, the child born with the both eye cataract, you can operate within 3 months. 3 months of time, because that is the time where the eye start getting focus. But if it is in one eye only, then it is more dangerous because the one eye goes deeper amblyopia very fast. So it has to be open, it has to operate anyhow within 6 months. Initially, it was a concept even 5 years back that until unless child get 2 years of age, we should not operate it. So that part has totally gone. By the time you have no advantage of operating child. And we have to definitely put the lens in the eye.
And now my last question is, you have not touched upon the damage to, as far as the cataract is concerned, by looking at the electronic screen, be it a smartphone, be it a TV, be it a laptop. Because I have learned that there is radiation from these equipment as well. So is there any study or any data which says that continuously, because many people are on their smartphone more than 5-6 hours a day, even 10 hours a day.
And
so
not only the smartphone, but the people who are working in IT section are working on the screen for more than 7 to 8 hours or even more than that. So definitely these kind of people are, these kind of group comes under the category of severe radiation. Whatever protection you provide on the screen, radiation has to be part of it. It has to become. So basically, we should protect these kind of people with the protective devices available on the screen, and rather they should be given often on exposure only. So if they can break for 30 or 40 minutes just to regain the eye into its normal position, I think that should be one part. Second, they have to protect with the protective screen, and I mean, that is the important part of that. So definitely you are very right that screen and mobile make the people even more vulnerable for getting the damage. And they are not only damaging the lens, they are damaging the retina as well. So the early retinal degeneration is also coming out in very big way.
Thank you, Dr. Anand. Thank you so much.
Thank you so much. Thank you so much, Dr. Jain, for asking those brilliant questions, because I think these were the questions that were in the minds of many people. So most of the people would have their answers with them. I have a couple of questions from attendee section as well, but just requesting our attendees to please just hold on so that we can first see that what our panelists have to say. and take the feedback and input, and then we come back to the questions. I have the question in Q&A and chat box. I'll be taking them one-on-one. Next question is in the chat box, and I think it is partially answered. Do photochromatic lenses protect from UV light? By Dr. Sanjay Rachilor. Dr. Sanjay, if anything you would like to add on to this question, you can please unmute and add. I think otherwise Dr. Anand has already probably given a perspective of photochromatic lenses.
Sir, basically the myopic person using photochromatic lenses constantly, will it give a protection from UV light?
Photorefractive.
Photochromatic, sir.
Photochromatic. In fact, I just told you the photochromatic lens are basically having the good mechanism earlier. Once you are getting at the new, so they have the better. If you can check yourself, if you just go them in the sunlight, they become more darker. And suppose you come in the out of that, you find they are fairly transparent. But what I have observed, and but everybody has observed, that the time this mechanism of moving the particles, which are responsible to make the glass little dark, became little impaired. So this mechanism stop, and the our purpose is lost. So initially it makes slightly less dark. Later on it makes the more darker. I mean less darker, and sometimes it will not at all. So the photorefractive false protection part should not exist. So my suggestion is either you should keep on changing the glasses frequently, almost in a year, and if you have to use long time, then I think they don't protect much, and they should be avoided.
Thank you so much, Dr. Anand, for answering and taking up the question. Now I move on to our National Secretary, Dr. Sandeep Sharma. Dr. Sharma, if you're available for your inputs and quick feedback, and if you have any question to Dr. Anand, please.
Thank you, Dr. Pawan.
Thank you,
thank you, Dr. Anand, for this lively interaction on this particular topic. Actually, this particular topic is very important for we all industrial physicians, especially those who are working in industries like hazardous industries, like we are working in oil and gas. So 24/7, we have to deal with these sort of problems. And our workers, they are exposed to ultraviolet radiation, infrared radiation when they work in heated atmospheres. And when our contractual workers, they are doing the welding jobs, and especially the tank truck crew, who all we are examining them, and we need to put some guidelines for them about the frequency of the checkups and the support which an organization can provide to them regarding examination, regarding cataract operations, or providing spectacles. So this we are doing at Indian Oil, and definitely railways also, since incident and accidents, they can be prevented if we are focused on this cataract prevention and early intervention. So it was a great talk, sir. So this was a very good topic, and I think everyone has benefited with this, and we will have it on our YouTube channel also for those who couldn't join today. So thank you very much, sir. I was traveling actually, so I couldn't join live on this program, but still the session was so lively, so I thought I should come in, and thank you very much, sir.
Thank Dr. Sharma. In fact, it is our responsibility to provide the prevention, protection, and the treatment at every level to our employee who are working with us, and it is our sole responsibility for maintain their good health. And a wonderful part of the body, and we have to take all best possible precaution and treatment. Thank you so much. We are really sensitive for it, and we all are in the same boat for concern to this.
Thank you.
Thank you.
Thank you so much, Dr. Sharma, for taking our time during your travel also, and Dr. Anand. Definitely, we can see that session is very interactive. There are many questions. We are not going to leave you quickly, Dr. Anand, because yes, there are a few questions, and because we have not touched upon COVID still. even a bit upon the relationship between this situation and the ophthalmic issues. So that definitely I have a couple of questions, but let me give the honor first to our panelists and over to Dr. Siva. He has already raised hand. Dr. Siva, please. You have to unmute, Dr. Siva.
Dr. Siva is from Bangalore.
Yes.
I am from Mumbai.
Mumbai.
Sorry, Mumbai.
Thank you, Dr. Anand, for the wonderful talk. I want to give an example of traumatic cataract of myself.
Oh.
30 years back, I got hit by a shuttle by playing badminton in my left eye. And I developed a traumatic cataract and I had to get it removed after 7-8 years. So you can get traumatic cataract even while playing. That is one. Number two is that there is a misconception about FICO among not only patients but also doctors. They tell laser surgery.
Yeah.
And as you know, there is no laser surgery for cataract. It is only FICO. But there is a wrong notion of laser surgery for cataract. And number three, which is now becoming a very fashion, is to get the lens replaced even without a cataract. To take care of the vision disturbances of eye myopia. There are people above the age of 40 who get their lens replaced to overcome this. And one more thing which I wanted to tell is for the IT people. Those who work in IT, with the laptop or computer for a very long time, the easy way to detect whether your accommodation is going on well or not is to go to a theater. First of all, when you enter, you will not see anything. Number two, when you come out of the theater, you will not be able to take the light outside. That means your accommodation has become very, very weak. And that is one of the reasons for cataract, because your light which goes into the eye is too high. So thank you very much, Dr. Anand.
Sir, I would like to give some, what you have just spoken is very correct, and definitely you are the sole example of getting the traumatic cataract by a subtle injury or 30 years back. Sir, now things have changed. Definitely phacoemulsification was not very premier at that time, and later on it was adapted to a good surgery. And it was definitely, you are very correctly said that it was not a laser surgery, but it was being projected laser surgery. But after the period of 30 years, if you permit me, if you have time, I have the video that now we are having true laser for cataract surgery, what you call robotic cataract surgery. Luckily, with that equipment I have with me, Dr. Gajendra very well aware about that. Though it is like costly, equipment costs around 5 crore and the consumable cost around 25,000 per eye. So it is definitely a costly affair, but now we are having a true laser for cataract surgery, very refined, very accurate, and very promising. So if you permit me, I have the video of that. I will just show you if the time permits. So
okay,
that part is
definitely, yeah.
Because it is robotic, which has come very recently.
Sir, it is basically a femto laser surgery. We call it FLAX, femto laser assisted cataract surgery. It's a machine manufactured by 4-5 manufacturers. The machine cost varying from 5 crore to 8 crore depending on the modules inside. And every eye have a consumable through which we pass the laser. I have the video. Luckily, I would like to show you that this is the latest technique in which we can correct the existing glass power. Suppose you are I just give an example. I was having gynecologist with me. She was using glasses from last 35 years. I operate her with the femto with both eyes, and she was perfectly working at the age of 62 without glass for near and distance. So now the technology has definitely gone up. So if time permit, I will show you. But now the true laser is available. Yes. Thank you so much.
Thank you so much for sharing. Thank you so much, Dr. Siva. and Dr. Anand for those insights. And yes, we will definitely like to have a look at the video. But there are questions which I would like you to
yeah.
first.
I will enjoying. I'm enjoying.
To the panelists, if any panelist, if any of our panelists has any quick question to Dr. Anand, else I'll quickly move on to our guests, Abhi Tarun and Rashmika Asokan. They have posted some questions. So quick check with the esteemed panelists. If any question or any feedback or comments from our panelists. Okay. You can probably, in case you want to give the inputs or have queries in between also, you can unmute and definitely pick it up. I will ask the question of posted by Abhi Tarun, if I'm pronouncing the name right. What type of workers are developing and presenting with premature cataract in your railway hospital at your department? Did you maintain any occupational eye injury registry? Two questions.
I didn't get the question. Sir.
Okay, it's in the Q&A box, sir. If you can maybe have a look at the question and answer box.
Please.
Yeah, what type of workers are developing and presenting with premature cataract in your railway hospital?
Yeah.
At your department?
Yeah.
Did you maintain any occupational eye injury registry?
Oh yes. So that is very important question they have asked, and now they have very specific to railway, in fact. So I would like to add it here that definitely we maintain whenever the person comes with the immature cataract. Right now, the number of people are coming with immature cataract because people are hardly wait for the cataract to be mature. But once cataract get mature, the person is become almost blind. Yes, I have seen number of cases with one eye having a mature cataract. So they are the rare cases, but normally people are coming with a mature cataract. So and second part, the injury register is a part and parcel of railway because when the employee come with us, we have to enter the detailed injury of the person because after that he will ask for compensation. So that record we are mandated to maintain. Whenever the injury is coming, when the patient is reporting to us, we try to maintain all kind of record or possible, including the age, the designation, date of injury, the type of injury, on duty, off duty, and what part of the eye has gone, and what is the vision status. And when we discharge the patient after treatment, again we record the same manner. So whenever a patient try to ask for compensation, all the information have a added value for us.
Great, sir. Thank you so much for answering. I hope the question is well answered to Abhi Tarun. To Dr. Asokan, another question, Dr. Anand, for you. In industrial setup, if radiation-induced cataract is noted, should there be a change in protocol and PPE usage be recommended by occupational hygienist regarding exposure, duration, and years of work exposure?
Very good question. In fact, if you look for the radiation, the atomic, I don't forget the full name, the Atomic Department of India. I mean, they are giving you the exposure, the kind of devices which the person has to put on their dress once they are working inside. And they keep on recording the kind of the amount of exposure they have come across. And once they regularly send it for check. And once it found that to be on the upper limit of that, the person has to be removed from the site. So that device is already available, and this is a government protocol. Even in the NABH accredited hospitals, in the organizations, not hospitals, where the chance of radiation are there, they are having even more sophisticated devices to just check the exposure with radiation. And if it is coming to the higher side, they have definitely to take the preventive measure or to remove the personnel from their place.
Thank you.
So that is already in practice.
Perfect. We definitely are, we have crossed the time for sure, but Dr. Anand, I must say, this is one of the most interactive sessions that we have been taking up. And there are more questions and more queries, but we'll have to hold it here. People will reach out to you maybe one-to-one, or we will help them take up their queries later on. Two last questions from my side, which has been in my mind. What's your take and perspective related to the rise in number of cases in COVID patient? Was it normal, or did you find that it was something related to the COVID-19 pandemic?
You are absolutely correct, but I have observed the number of patients has slightly gone up. And probably it is not the direct invasion or involvement of the COVID, but I think the steroid therapy people have taken, which is a known factor, a known drug, intoxicant, which can predispose the cataract formation, particularly in the comorbid patient like diabetic and all. So the steroid oral injection of steroid in high dose, maybe for a long time, they definitely have the cataract formation.
There were multiple ophthalmic issues. This was not cataract, but then people were exposed and they were seeking consultation from ophthalmologists at a very high number. Whosoever was exposed to COVID, many patients were looking for eye consultation. Was it some there? Did you find some link there?
Actually, all viral infection are having some pathology related to the micro muscles of the eye. So right from the accommodation failure, right of the metabolism of the cornea and the lens, even the nerve which is conducting the stimulus to the brain is also get involved. So probably it is very difficult to find out the site of the lesion involved with this. But or we can just try to find out the reason behind it. It could be the steroid, it could be the virus, it could be the long-term weaknesses, but definitely, or the treatment, oxygen therapy, everything, that has to be studied in future. But definitely people after COVID are coming with various kind of problems with even high incidence of cataract formation and infection as well.
Thank you for answering that, Dr. Anand. I think it would require a lot more research, but there is some link which we'll definitely come to know. The other quick question that I have on my mind is a lot of skin exposure has increased because of online classes, because of people remaining at their houses for very long hours, no movement outside. Are we looking at developing some SOP just like we developed SOP related to telemedicine or video consultation? Lately, Government of India and other authorities developed those SOPs and protocols. Similarly, since you are key member and key office bearer of many organizations, many societies, are you looking at developing some SOP, some protocol for these kind of online exposures related to online classes or use of too much of usage in the home by family and also by kids? Please.
It is a very wonderful question, Dr. Pawan. In fact, we are working on the issue that how we can help the people who are just inside the house arrest because of some reasons. They need change of glasses. They need change of their eye checkup. Suppose somebody is glaucomatous, somebody is uveitis. I mean, these are the people who are, or the age-related macular degeneration. These group of patients are definitely require a close observation, the close watch, right? Because we have to give them the periodical visit to the hospital. We check their retina, we check their thickness, we check the cataract formation, we check the glasses, we check the tear formation. Right. So these are the things, basic examination for it. But now once in the COVID situation, people are scared. Even the doctors are not available. So I have just made some kind of questionnaire to the people we are sending on their WhatsApp to these group of patients. Suppose you have your own way of checking the vision in your house. Suppose you have put some image at the distance of 3 meters or 6 meters, you keep on watching with the both eyes separately every day. And if you find that it has gone blurred, it has gone down, or it is not visible as clear as it was, so we have to visit a nearby doctor.
Okay. So good. But regarding developing SOP for these online classes, anything on that?
Own classes,
online classes, which are very frequent now. Kids are getting exposed a lot. Any protocol related to that in future?
In fact, online classes you can provide, but you have to check it. Even the person, I mean, domiciliary glass examination is possible now. So patient need not to come to the hospital just to get glass number change or check. So now the lot of government, non-government organizations are coming, and a lot of companies are coming rather. So they are giving you a domiciliary visit to check your power, distance as well near, and they are giving you the good glasses at their residence only. So this part is being taken care of already.
Thank you so much. But I definitely, from my perspective, look forward to some protocols and SOPs related to this current online classes scenario for kids.
But
please give it a thought in the future.
Right. We are also looking at how we can help to be set group number of patients who definitely require our attention, but because of some reason not able. So how kind of guideline we can issue them for their own check? Yes, definitely. It is already in my mind.
Yes. Thank you so much, Dr. Anand. With that, I mean, there are questions, but then we will have to stop here. We have really crossed the time, but then it was really wonderful of you sparing, taking all the questions in full spirit. On behalf of the AOSD organization, I thank you so much and really appreciate you sparing time this evening. we would definitely like you to stay behind with us, because Dr. Rajiv Jain definitely is going to share insights related to current situation of COVID for India and global scenario in the next presentation, which will be of approximately 20-25 minutes and some Q&As. So with that, we thank you once again.
Thank you so much. Thank you so much, Pawanji. I'm really honored with you, talking to you, to your groups, and with the learned people over here. Thank you so much.
Pleasure, sir. Thank you so much. With that, okay, thank you so much, sir. With that, we move on to our next session, and we have Dr. Rajiv Jain with us. So sorry, sir, for keeping you on wait. Apologies, but the session was so interactive, and so everybody was so inquisitive, so we could not hold. The e-platform is set for you, and we can see you now. Very good evening, Dr. Jain. I hope you are able to see us. We cannot hear you. Probably the mic is on mute, sir.
No, it is on at the moment.
Yes,
I hope you are. Yeah.
Now we can see you and hear you. Thank you so much. People know you very well, sir, but a quick introduction to all esteemed panelists, to attendees, and to the audience present here of Dr. Rajiv Jain, who would be sharing COVID-19 Epid updates as a regular feature, and this also is going to be a half century for this very soon, and we are really privileged. Dr. Jain is a senior consultant, health, Indian Railways, New Delhi. He has 40 years of experience in health and hospital administration, fellow award of Indian Public Health Association, fellow award of Association of Environmental and Occupational Health Delhi, published, presented more than 145 scientific papers in national, international conferences, journals, and books. Fellowships, scholarships by World Health Organization, National Institute of Health, USA, Canadian Society for International Health, International Clinical Epidemiology Network, and International Society for Priorities in Healthcare. The list is long, sir. We know that. These are a couple of pages. And so we are not going too much into the detail of it, but I'm handing over the e-platform to you for the session that you have been taking and the thought that you have been sharing. Over to you, Dr. Jain.
Thank you, Dr. Pawan. So after a wonderful discourse on cataract and occupational health by a learned ophthalmologist, we come here back again on a Saturday evening. And today, on 27th of November 2021, we again take a stock of the COVID-19 epidemiological situation, whether it is in the country, in the districts, whether it is regional in Asia or other continents or in the world, and go beyond as to be able to understand where the epidemiological situation of COVID-19 is today. It's important all the more because the way things are evolving, it underscores the importance of continued vigilance, continued surveillance, continued understanding of how the COVID-19 infection is spreading across the world. So before I start, I will like to share a small video. As we are doing in India, the COVID-19 epidemiological updates, Singapore University, National University of Singapore is also organizing once a month webinar on COVID-19. And on Thursday this week, they celebrated a final episode of that event. I would like to play a small video sharing with you how the COVID-19 pandemic evolved since December 2019. Imagine, it's been 2 years and it seems like yesterday. and how fast the world will keep on changing, as you shall understand during the course of this presentation. So if we come back to the presentation, let's have the first slide for the new event that has occurred during this week. That is, next slide, please. That is the threat on the horizon. Several stock markets plunged. Countries rushed to announce new curbs on arrivals from African countries, and the World Health Organization held an emergency meeting over a new variant of concern. What we know so far about the SARS-CoV-2 variant, worrying scientists. Omicron, another variant of concern, known as the 8B.1.1.529. The variant was first detected by scientists in South Africa on November 12, after an unusual spike in infections in the country and Botswana. It is the first variant since Delta to demonstrate the sort of worrying signs that signal a dangerous variant. The WHO on Friday held an emergency meeting, after which it announced a new variant of classification, concern classification, Omicron. Let's hear the lead scientist of the WHO talking about it in the video now.
So today, WHO's Technical Advisory Group on Virus Evolution met to discuss the variant B11529, to discuss what we understand about this variant and if it should be classified as a variant of interest or a variant of concern. Based upon the information that we have, particularly from South Africa, they have advised WHO that this variant should be classified as a variant of concern. So today we are announcing B11529 as a variant of concern named Omicron. So Omicron B11529 is named as a variant of concern because it has some concerning properties. This variant has a large number of mutations, and some of these mutations have some worrying characteristics. Right now, there are many studies that are underway. There's a lot of work that is ongoing in South Africa and in other countries to better characterize the variant itself in terms of transmissibility, in terms of severity, and any impact on our countermeasures like the use of diagnostics, therapeutics, or vaccines. So far, there's little information, but those studies are underway. So we need researchers to have the time to carry those out, and WHO will inform the public and our partners and our member states as soon as we have more information. Once a variant is classified as a variant of concern, it's really important that we have good SARS-CoV-2 surveillance around the world, including better genomic sequencing, because we want to be able to detect this variant where it is circulating. It's also really important that studies are undertaken in the field to look at any clusters, and also the studies that are needed in the lab to look to see if there's any changes in severity, any changes in our impact on diagnostics, therapeutics, or vaccines. The Technical Advisory Group for Virus Evolution will be meeting regularly about Omicron. It will take days to weeks for some of these studies to be undertaken. It's really important that these studies are done, and they're done comprehensively. As soon as we have more information, we will make that information public. But it's important to know that there's a lot that you can do to keep yourself and your loved ones safe. We understand that people are concerned. The good thing is that we have monitoring systems around the world to detect these variants very quickly. This variant was detected a few weeks ago, and already scientists are sharing research with us, information with us, so that we can take action. What's really important as an individual is to lower your exposure. The measures, these proven public health measures, have never been more important. Distancing, wearing of a mask, making sure that it's over your nose and mouth with clean hands, making sure you avoid crowded spaces, be in rooms where there's good ventilation, and when it's your turn, get vaccinated.
So, once again, the basics of prevention from the viral infection of this nature. It underscores that you need to continue to practice what you have been practicing for the last 2 years, and all the more, because vaccine alone will not prevent you from getting infected. And if it's a new virus, especially variant of concern, you may not have the protection in spite of being vaccinated. So the alarm, let's understand the science. Why the alarm? There are 3 factors driving the worry. The rapid jump in infection recorded in South Africa is number 1. According to reports, the country reported close to 2,500 new cases on November 25. which is over 320% of the average number of new infections seen just a week ago, when the number was only 650. Of particular concern is the situation in Gauteng province, where test positivity in one particular region, that is Shuane, jumped from 1% to over 30% in 3 weeks. Sequencing there showed almost all recent samples are of B.1.1.529, outcompeting Delta in a way not seen before. Second, mutation profile of the virus. There are a whopping 32 mutations in the spike protein, that part that latches onto human cells. For the first time, scientists have recorded 2 mutations at what is known as a furin cleavage site, the segment of the virus that is responsible for its entry into human cells. And the third, many of these mutations have separately been seen in 3 other variants of concern, that is alpha, beta, and delta, which means the variant has demonstrated higher transmissibility and has a host of mutations that can cause a sizable antigenic shift, the scientific term for a pathogen to have changed significantly. These are the 3 reasons why the alarm has been sounded yesterday evening by the World Health Organization, and Indian government has got activated. Today, the Prime Minister held an emergency meeting. What does it mean for the vaccines? Early signs show that the variant has major immune escape mutations in each of the 3 portions of the SARS-CoV-2 that are targeted by antibodies, both natural and those elicited by vaccines. But that still does not mean the variant will fully escape vaccine or infection-elicited antibodies. Scientists have said, citing past studies that show how the body's response mechanisms trained by infection or vaccines deploy a host of tools to fight the pathogen. So what do we do next? It is crucial to remember all the information at present is preliminary, and scientists are throwing everything at this development to understand what it means. The variant will now be analyzed on 3 parameters. Does it spread more rapidly? Does it defeat immunity from past infection or vaccines? And does it cause more severe disease? The answer to these questions could take a couple of weeks. Till then, it is likely countries will restrict arrivals from countries where the variant has been detected, like UK, Israel, and Singapore already have. Next slide, please. So, more than 100 plus sequences are already reported. WHO officials said over 100 sequences of the new variant have been reported in Africa, centered around South Africa and Botswana. 2 confirmed cases in Hong Kong, a man from South Africa, and a man who was staying in the opposite room. 1 confirmed case and 3 suspected in Israel. 1 person, a traveler from Malawi, was a confirmed case, while 3 others were suspected cases. 1 confirmed case in Belgium. It became the first nation in Europe to confirm a case of new variant. A British virologist, Ravi Gupta, said, "This one is worrying, and I have not said that since Delta." So it's important to understand the evolution of Omicron and how it is spreading across the world if we have to really protect our population and be prepared to face another wave. Next slide, please. This is the official statement yesterday night by the World Health Organization, the Technical Advisory Group on SARS-CoV-2 virus evolution, that is TAG-BE, is an independent group of experts that periodically monitors and evaluates the evolution of SARS-CoV-2 and assesses if specific mutations and combination of mutations alter the behavior of the virus. The TAG-B was convened on 26 November 2021 to assess the SARS-CoV-2 variant B.1.1.529. The B.1.1.529 variant was first reported to WHO from South Africa on 24 November 2021. The epidemiological situation in South Africa has been characterized by 3 distinct peaks in reported cases, the latest of which was predominantly the Delta variant. In recent weeks, infections have increased steeply, coinciding with the detection of B.1.1.529 variant. The first known confirmed B.1.1.529 infection was from a specimen collected on 9 November 2021. This variant has a large number of mutations, some of which are concerning. Preliminary evidence suggests an increased risk of reinfection with this variant as compared to other variants of concern. The number of cases of this variant appears to be increasing in almost all provinces in South Africa. Current SARS-CoV-2 PCR diagnostics continue to detect this variant. Several labs have indicated that for one widely PCR test, one of the 3 target genes is not detected, called S gene dropout or S gene target failure. And this test can therefore be used as marker for this variant, pending sequencing confirmation. Using this approach, this variant has been detected at faster rates than previous surges in infection, suggesting that this variant may have a growth advantage. Next slide, please. There are a number of studies underway, and the tag B will continue to evaluate this variant. WHO will communicate new findings with member states and to the public as needed. Based on the evidence presented, indicative of a detrimental change in COVID-19 epidemiology, the tag B has advised WHO that this variant should be designated as a variant of concern. And the WHO has designated B.1.1.529 as a variant of concern named Omicron. As such, countries are asked to do the following. Number 1, enhance surveillance and sequencing efforts to better understand circulating SARS-CoV-2 variants. Number 2, submit complete genome sequences and associated metadata to a publicly available database such as GSAID. Number 3, report initial cases and clusters associated with variant of concern infection to WHO through the International Health Regulation Mechanism. And number 4, where capacity exists and in coordination with the international community, perform field investigations and laboratory assessments to improve understanding of the potential impacts of the variant of concern on COVID-19 epidemiology. Severity, effectiveness of public health and social measures, diagnostic methods, immune responses, antibody neutralization, or other relevant characteristics. Individuals are reminded to take measures to reduce the risk of COVID-19, including proven public health and social measures such as wearing well-fitting masks, hand hygiene, physical distancing, improving ventilation of indoor spaces, avoiding crowded spaces, and getting vaccinated. All these will have to be continued to be practiced. Next slide. Let's see the situation in India now. This is a list of districts where the infection weekly positivity rate for the week 19 November to 25th November is more than 10%. This is alarming. You see Kerala, Wayanad 13.38% positive, Kozhikode 12.16, Tirunelveli 11.81, Kottayam 11.5, Idukki 11.42, Kollam 10.14, Ernakulam 10.11. And in Mizoram, the districts are Sarchip, imagine 21.5% samples positive, Lungle 17.16%, Champhai 16.64, Nathal 15.93, Namit 13.62, Saitwal 12.37, Aizawl 12.15, Longtai 11.76, and Nagaland, imagine Perin, the highest in the country. Perin district in Nagaland is showing 25% positivity rate. Now, these are the list of districts in India for the week 19 November to 25th November, showing positivity rate between 5% and 10%. In Assam, it is Dima Hasao. In Kerala, it is Kannur, Thrissur, Patamteta, Alappuzha, Palakkad, and Kasaragod. In Ladakh, it is Leh Ladakh. In Manipur, it is Imphal West and Imphal East. In Meghalaya, it is East Garo Hills. And in Mizoram, it is Kolasib. And in West Bengal, Kolkata, it is 6.55%. So it is very much there. Infection is spreading, continues to spread, and the positivity rate in the district I've shown you in this slide and previous slide is more than 5%, and in number of districts is more than 10% for the past week. So you have to be on guard and continue to be on guard. Next slide, please. This is the situation of Southeast Asia region, the region which is surrounding us, including India. Since July 2021, the incidence of cases and deaths in Southeast Asia region continues to decline with 136,000 new cases and 2,800 new deaths, decreasing of 11% and 19% respectively as compared to the previous week. Only one country, that is Bhutan, reported an increase of over 10% in new cases in the past week. 7 new cases, a 250% increase, whilst the highest number of new cases were reported from India, 73,000 cases, 11% decrease, Thailand, 46,000 cases with 8% decrease, and Sri Lanka, 5,084 cases with 19% decrease. The highest number of new deaths were reported from India, 2,132 with 22% decrease, Thailand, 351 new deaths with 8% decrease, and Sri Lanka with 132 new deaths, and similar to the previous week's figures. And you see the graph of the pandemic in Southeast Asia region, where you find the graph has not yet touched zero. It is well above zero. It is both deaths and cases. It is yet to reach zero. It is very much evident that the pandemic is still on in Southeast Asia region. Next slide, please. Let's go beyond Southeast Asia region. This is the global graph where each region of the WHO has been shown with a different color. And if you see extreme right, the dominant color is green. And what is green? Green is Europe. And second dominant color is yellow. And yellow is Americas, both North America and South America. And at the bottom, you see Western Pacific, which is purple. And green is very small Eastern Mediterranean. And blue is Africa, is very, very small in terms of proportion. So European region reported an 11% increase in new weekly cases, while Southeast Asia and the Eastern Mediterranean regions reported decrease of 11 and 9%. So the infection is still there in Europe, and it is spreading, and it is on the growth path. Next slide, please. This is the proportion of cases. If you look at change in new cases in the last 7 days, only 11% increase has been there in Europe. All other regions of the WHO are showing decrease. With the result, globally, there has been a 6% increase during this week compared to the previous week. Out of 100 cases being reported this week, which were 35,97,000, the maximum, that is 67% of the cases, were reported from Europe. In terms of deaths, 57% deaths occurred in Europe during the week. And there has been increase in number of deaths during the last 7 days compared to the previous 7 days in 3 regions of the world. 3% increase in Europe, 19% increase in Americas, and 29% increase in Western Pacific. And globally, 6% increase. Next slide, please. This is the graph of the 6 WHO regions separately. And if you look at the graph on the right top, green color, Europe, what do you see? You see a huge spike. The highest wave of the pandemic is happening now in Europe. While on the other hand, if you see what is happening in Southeast Asia is going down, Eastern Mediterranean going down. In Americas, it is not going down, it is going up. On the other hand, Western Pacific is stabilized at a high level. Africa is now again starting to go up. And remember, Africa has shown a new variant of concern, that is Omicron. Next slide. These are the graphs of, in this graph, there are 6 countries from highest to lowest. United States of America, you see the graph of the pandemic, and India, you see Brazil, and you see United Kingdom. What do you see? In United Kingdom, it is going up. Again, you find in Russian Federation, it is the highest wave of the pandemic. In Turkey, it is stabilized at a plateau at a high level. Next slide. This is the graph of next 6 countries. France, it is going up. Iran, it is stabilized. Germany again has shown a huge spike. If you look at the right of the graph of Germany, Argentina is now plateaued. Spain has again started to go up. Colombia is plateaued at the moment, but we do not know whether it will remain so in the future. Next slide, please. These are the top 9 countries in the world who have shown new cases in the last 7 days. And the ranking is United States of America, number 1, 6,66,000 cases. Germany, number 2nd. Can you imagine? Germany is number 2nd in the world, 4 lakh cases. United Kingdom, 2,99,000 cases. Russian Federation, number 4. Turkey, number 5. France, number 7. Poland, Netherlands, and Czechoslovakia are also in the top 9. Next slide. This is the ranking of the countries in terms of deaths newly reported in the last 7 days. Number 1 is USA with 10,000 deaths, and last 24 hours, 1,387 deaths. Russian Federation with 8,000 deaths in 7 days and 1,235 in last 24 hours. Ukraine, India, Poland, Germany, Brazil, Romania, and Philippines are showing deaths which are more than 1,000 during the week. And these are the top 9 countries showing the highest number of deaths during the last 7 days. Next slide, please. This is the map of the world where the color dark brown, the darkest brown, is to the countries which are showing cases per 1 lakh population during the week of 15 to 21 November 2021. And what you see, the darkest brown color is in Europe, and especially Eastern Europe and Northern Europe. Next slide, please. This is the map of the world with deaths per lakh population for the week 15 to 21 November, and the darkest blue shows the highest number of deaths per lakh population. And where do you see the highest proportion of deaths, concentration of deaths? It's in Eastern Europe. So Eastern Europe, highest number of cases and highest number of deaths in absolute numbers as well as in numbers per lakh population. Next slide, please. This is again important 4 variants of concern, last 60 days, historic detections data. This is GSAID and WHO data as on 23rd November 2021. And what do you see? Predominantly, globally, it is the Delta variant which is predominating. And if you look at the south of Africa, at the place where South Africa is located, Delta variant has now started being replaced by Omicron. And that is what is worrying. And also Gamma is predominantly in South America, and Alpha and Beta is very restricted to very small regions of the world. Especially Beta is in South Africa and Alpha is in Southeast Asia region, especially Indonesia. Next slide. This is summary of phenotypic impacts of variants of concern. In terms of transmissibility, Delta variant shows increased transmissibility and disease severity. In Delta is possible increased risk of hospitalization and risk of reinfection is there. With reduction in neutralizing activity reported in Delta variant. Impact on diagnostic, fortunately, no impact on RT-PCR or a rapid diagnostic test has been observed. Next slide, please. So, in the end, I would like to again apprise the audience about an important event which is going to happen by WHO from 13 to 15 December 2021, the 10th Global Conference on Health Promotion for Well-being, Equity, and Sustainable Development. And it's free for everybody in the world to attend. Just register yourself at the website 10GCHP. G for global, C for conference, H for health, and P for promotion. 10gchp.org, and you can attend the 3 days of excellent sessions on health promotion and for well-being, equity, and sustainable development by the World Health Organization from 13 to 15 December, right from your home or workplace and get to understand what health promotion is all about. And it's important for all occupational health practitioners to understand what health promotion means, and it's all the more important during the COVID-19 pandemic. Next slide, please. So I would like to thank you for your attention, because attention is the rarest and purest form of generosity. And I thank you for your generosity. Thank you so much.
Thank you so much, Dr. Jain, for your kind gesture once again, for sharing those insights, highly concerning though. Situation is far from getting over. We really appreciate your gesture of continually gathering, consolidating, and keeping all of us updated on the developments which were actually very crucial at times and which definitely helped. A lot of times we have deliberated, reciprocated, and openly discussed with you on the situation and how it can be handled and managed well. People have learned a lot. We are always very thankful to you for all the time that you have spared and all the contribution that you are continually making. Really appreciate. With the due consideration of the time that we have in hand, I see the hand is raised by our President, Dr. Jain Kumar. So straight away, handing this e-platform to Dr. Kumar for the question that he has on his mind. I have a couple of things, but then I'll be taking up later. Please, Dr. Jain, over to you.
First of all, I compliment Dr. Rajiv Jain for a wonderful presentation. See, my observation is this new variant, which is the virus of concern, though it is there in African countries and other countries, but one very important finding which I could find out, that the number of cases in Germany, it has gone up tremendously. It is now number 2 in the world.
Yeah.
While in India, the number of cases were plus 70,000 in a day. In India, the number of cases was less than 10,000 or around 10,000. But the number of deaths in India is far more than what it is in Germany. So I need your comments on that.
There are multiple reasons for it. The kind of variant of concern predominating and the way it is spreading. Delta variant in second wave in India was a major cause for increased death, because the virus had just evolved during that period, like April, May, and June. In Germany, the situation is a little bit different. If you look at the population of Germany and the people who are vaccinated and the people who have access to complete healthcare, remember, Germany is one of the best publicly funded healthcare system in Europe. The entire cost of treatment is borne by the government. It's a social safety network is very high in Germany. And Germany has another advantage. It is the highest number of ICU oxygen supported beds in the world. No country in the world has that much concentration of ICU beds, especially ICU with qualified intensivists as well as oxygen supported beds. So there are a number of factors which determine this. Another interesting reason that you are seeing the upsurge in Germany now, there is a bit of restlessness and there is a feeling of refusal to get vaccinated. There's a sizable population and sizable area in Germany due to political reasons or religious reasons. They do not want to get vaccinated, and they're not silent. They are demonstrating on the roads and they are agitating. Restrictions should not be put. In all Western democracies, they have access to freedom of speech and freedom of press. So they are paying the price of that freedom. What we require during pandemic is control on that freedom in a measured manner, so that the infection spread, the speed of spread could be controlled. That is not able to be done because the price of political controls will be very high. The government is fearful that it will lose. Second, another reason, if you see, Germany is in transition phase. The new government is going to take over. The previous government has gone, but continues to take care. So the loosening of the system, the federal system in Germany, is also a factor. There is a coalition always, and the new coalition is going to take over in Germany in about 2 weeks from now. So there are a number of factors which play all this role. Germany is going to face a major challenge. If you realize in Germany, there's a sizable African population.
Yeah.
There's a sizable Central Asian population. It has a few of the highest number of refugees who are officially taken in by Germany as a political, I say, asylum or whatever. So they are also a cause for transition due to travel between the origin countries and Germany. So it's a multifactorial reason.
Thank you. Thank you very much.
Thank you so much, Dr. Jain, for taking up that question. The one reason could be I correlate with my professional engagement currently. Germany has recently done a physical Medica conference, one of the largest medical conference in the world at Düsseldorf. It was concluded last week. And there would have been a high number of travel engagements in Germany, though people have not traveled much from, to whom I know. But then, yes, it was a physical conference attended and done during this phase of time. Could be one reason, because this time of year when Medica happens, Germany has really higher influx of people from across the globe. So that is, I am not a subject matter expert, but then just trying to correlate, because what I have seen, that people whom I know, they are also, they got they got somehow infected, although they were vaccinated. And as Dr. Jain has just mentioned, that Omicron, definitely a new variant is there. But yes, people are getting infected even after the vaccination. So though they have, they were vaccinated twice, and then also. So let's see. And on your take of mortality part, which Dr. Jain has definitely answered, that is definitely on the lower side. There could be multiple reasons to it, but I just related.
I think the COVID restrictions fatigue is now taking its toll.
Yes, that is like just like revenge or revenge going outside. So it's kind of that factor. And I personally, they were like last 3 months, it has been like thrice that my travel has been cancelled to Europe because of this evolving situation. Next week I was supposed to be there, but I've cancelled. They have cancelled the meetings. So things are definitely.
But Dr. Pawan, an important decision has been taken by Government of India. Opening of international travel from December 15. So there are issues which politicians will have to take all factors in view, and nobody can stop now international travel, as Dr. Gajendra Kumar has already mentioned. Fatigue. So the general feeling in the policymakers and diplomats is that opening up of international travel has to happen.
Yes, I completely agree with that. Yes, with that I move on to Dr. Pingle. Dr. Pingle, if you're hearing us, your thoughts and inputs and some quick feedback, or if you have any question, please.
Thank you very much.
Thank you.
Am I audible?
Yes, very much, sir.
Yeah, because I had poor signal here, so I was shifting between two mobiles, two connections. As usual, it is very interesting, but at the same time, this new variant is a matter of concern. And we don't know enough. And the present situation reminds us of the beginning of this pandemic, wherein few cases were seen at some places, and by and large, people ignored it. So maybe on one hand, there are people who are stopping the flights, and on the other hand, we are starting the international flights.
Correct.
That's an interesting situation, actually. And the pressure is so much. If you see all the statements from all the people involved in UN system and Western countries, they insist that this opening up of international travel should continue in spite of the news of Omicron.
I still remember WHO has advised that nobody should wear a mask when the pandemic broke.
Very true.
At that time.
That's the paradox.
So I don't know how much credibility WHO should have.
Yes. I was remembering, Goan chief day before yesterday on Thursday webinar, Singapore. He was also mentioning this, what you mentioned initially, what WHO advised, which was diametrically opposite of what science had dictated.
Yeah, absolutely. And then one last thing, WHO has been naming these various variants on the Greek alphabet, but they have skipped some alphabets.
Nu and Z.
obvious reasons.
Yeah.
Now, that shows where WHO's loyalties lie.
Yeah. It's very much in the news, Dr. Pingle, Nu and Z, why they have been escaped, and it's all over the world. Actually, you are absolutely right. Everybody is thinking on those lines. Yes.
Yeah. Okay. Thank you. Thank you so much.
Thank you so much, Dr. Pingle, for sharing your thoughts. I can see
Pingle has
Dr.
been, Dr. Pawan, he should be given the highest attendee award for our COVID-19 Epid updates. He's such a regular listener, a silent listener.
yes.
I must appreciate the way Dr. Pingle has devoted his time
Yes.
to our webinars.
I agree.
Yes. We are very grateful, and he has definitely been there in most of the webinars that we have done, and he has contributed as well.
Your Honor, it is not your webinar; it is our webinar.
Absolutely.
But we see you as a representative of ICO. You being the ICO board member from India, so that's all the more significant. So I'm speaking from that standpoint. You are a global ICO board member.
Yeah, we are privileged, Dr. Pringle. Thank you so much. Yes. Over to Dr. Thagraju, the constant contributor and a constant, I would say, support system. Dr. Thagraju, if you are listening to us, your inputs, thoughts, and also if you have any question to Dr. Jain or to Dr. Anand. We are really thankful to Dr. Anand. He's still there. If anyone has any question related to the previous session, they can definitely take up now. Dr. Thagraju, you able to hear us? Okay, some glitch, I guess. Our National Secretary, then Dr. Sandeep Sharma. Please, if you are listening and if you are able to talk, if you're not traveling, if you're comfortably, you can unmute and talk. Then Dr. Sharma, please. Okay, I think he is into. Oh, I can see Dr. Siva has raised the hand. Dr. Siva, please. Please, over to you.
No. First of all, Rajiv, excellent. As usual, excellent. Now, one of the reasons for increase of cases in Europe, Russia is because of winter. Because in winter, they meet inside in closed spaces. They don't meet out. So that is one of the reasons for increased infection in Europe, and it is a festival time now.
Yeah.
All this Thanksgiving, everything is going on. So that is one of the reasons.
Possibly, yes, Dr. Shiva, thank you so much. That could be one of the more important reasons, because people are preparing for Christmas and for New Year, and many meetings are being planned, but then yes, at the same time, they're being cancelled as well. The kind of meeting that I was mentioning, yes, they are taking due precautions. Dr. Parekh, if you're able to hear us.
Yeah, Dr. Pawan, good evening, everyone.
Good evening, sir. Thank you.
Both the session excellent. Usually we talk about chemical injury in the eyes, but this time the topic chosen excellent, cataract, and we come across lot many cases of cataract in the industry. So it was very wonderful session. At the same time, as usual, Dr. Jain sir and same excellent presentation. But we are worried about new variant. But at the same time, at present we are happy that it is not in India, but later on, see, as Dr. Pingle sir told, that initially we were in phase in the beginning, but later on it is transmitted like anything. So let us hope for the best that new variant will not transmit in the India. So it is excellent, sir. Thank you so much.
Thank you very much.
Excellent moderation.
Moderation
is excellent. Thank you so much.
Appreciate, sir, for your kind gesture. Yeah. So open platform for all the panelists and attendees. I could not see any questions or any more raised hand here. If anybody would like to contribute anything, otherwise definitely we have crossed our timeline, but it was required need of the hour.
Session. Yeah. Almost reached 2 hours of the session.
Yes, today we have Dr. Sandeep Sharma has raised the hand. Please, Dr. Sharma.
Yeah, thank you, Dr. Pawan.
Thank you, sir.
Really, it was a great session with Dr. Anand and Dr. Rajiv Kumar Jain, sir, as usual. And yes, in the light of this yesterday's discussion and declaration by the WHO, this new variant, everyone is now worried, especially in India and the industries also. So But this worry is good because in the sense that we were having lot of complacency and people were not following the COVID appropriate norms, and they were thinking that the things are over right now. But still, even if this variant is not there in India, but still we have to follow all the WHO advices and the COVID appropriate norms. And yes, this has also opened the discussion about the booster dose also. So a very lively discussion, sir, Dr. Rajiv Jain, sir, and it was really a very good session. And thank you very much, Dr. Pawan, for moderating the session.
Thank you so much, sir. Thank you so much. Really appreciate it, Jasha.
Interesting factor which Dr. Sandeep had raised. Now, I think the pressure on the government to open booster doses, especially to the healthcare workers, in the light of the VOC Omicron, I think that will come earlier than we expected. That will be one fallout of this evolution of the pandemic.
Yes, sir. Thank you so much for those interesting insights and also for this reciprocative. And as it was so indulging discussion that I could not stop it anywhere in between, and we have definitely crossed, probably taken 30 minutes more from our usual timeline. But then both the sessions were extremely informative. I really thank to both of our esteemed speaker on behalf of AOSD, and extend gratitude for sparing your time. Thank you so much to Dr. Anand, and thank you so much, Dr. Jain. With that, I would like to conclude today's webinar, and we look forward to catching up again 6:30 p.m. prime time next Saturday. For this, link will be posted on YouTube for today's webinar and also on our various social media platforms. Those who could not join in or who would have skipped, they can definitely take a look at it in their own comfortable time. Thank you very much.
Thank you.
Thank you. Thank you, Dr.